Hello, everybody. Very nice to see you all. I'd love to know where you're all from, but we don't have time to find that out, I guess. But not just San Diego. Good. This should be very instructive. The more we talk about this, the better. Phoenix, aha. Okay.
Yes, they could type in where they're from in their chat if they want to.
Oh,
Yeah.
what are we doing here?
Just put the chat up in case anyone, yeah, people are telling you where they are. We've got
Oh.
Brooklyn, California, Monterey, Seattle, and Boulder, El Dorado Hills, and Australia. Okay. Austin, Texas. Yeah. San Diego, Chico, California. That's interesting.
This embodied voice on my right is my daughter,
It
who's
is.
visiting me from Australia. So,
So I'm moving to San Diego soon. Yeah. I'm not in Australia right now. That is where I
no,
live. Yeah. Which has
she leaves tonight, actually, to go back to the land of kangaroos.
Anyway, so that's a good. Someone else from San Diego. Yes.
Okay, I'll start in 1 minute.
See what else comes through there.
Hello, everybody. I see people here from Oregon and North Carolina and all sorts of places. It's very happy, very nice to have you all here. I think you'll enjoy this program. I'm Faye Gersh. I'm the president and founder of the Hemlock Society of San Diego, now in its 39th year. So welcome to this program featuring three highly qualified and experienced physicians who have expressed their support for medical aid in dying, or MAID. Our apologies for changing the venue at the last minute. We love the idea of a group of people meeting at the library who can touch the speakers and raise their hands and be much more informal, but there are too many of us and we don't know how to do it right. So we're doing this by Zoom instead, which permits those people who want to see it again on our website to look at it there. It'll be there forever. And people who can't come today can also watch it on our website. We're very happy that a good chunk of our audience doesn't live in San Diego, because we'd like this information to go around the country, around the world if necessary. Today's program is part of our public education mission presented by the Hemlock Society of San Diego to educate the public on the right to die in all its complexities. We've been doing this now for almost 40 years with your support. Things we know. MAID, medical aid in dying, is underutilized in California and generally in those jurisdictions in which it's legal. And partly that stems from a lack of knowledge of people and doctors and medical professionals who don't know about what the law is and what it permits and what it should be, maybe. And we know that laws that we now have are inadequate. They don't serve the population, the whole population who would benefit from them. And we also know that doctors as a group don't actively promote MAID at the end as an end of life option. We hope that after a medical professionals will take this program to heart and talk more about medical aid in dying to their patients and to their fellow physicians. It's my pleasure to introduce our three distinguished speakers. Where are they anyway? Hold on. There's only two of them here present. And one of them is on the plane going to Illinois. So we'll introduce him and he'll talk to us by remote. Um, uh, Curtis Crock is his name, by the way, and he's now on our Hemlock board. So you can see more of him, even though you won't see him in person today. We've asked our speakers to say why they support MAID, what they might like to see changed in the law, and to reflect on what they'd like for their own deaths. Let's start with Dr. Bob Gunn. Bob, raise your hand. Can we see you? There you are. Bob Gunn is a board certified preventive medicine, popular topic these days. What with the controversy of vaccination and Robert Kennedy. Bob holds a MD from Yale and an MPH, Masters of Public Health, from UCLA. He's worked internationally at the London School of Tropical Medicine, in Guam, at the US Naval Hospital, and in Brazil with Project Hope. He also worked in public health in Florida and Los Angeles, and has had several stints at the famous and now almost defunct CDC, Centers for Disease Control, in Atlanta. He retired from 30 years in the United States Public Health Service and continued in various capacities at UCSD, University of California, San Diego, and is still active in the area of sexually transmitted diseases. During his career, he has published 114 scientific articles as author and co-author. But that may still not be clear with his background why he supports MAID, and that's what he's going to tell you about. So, Bob, you're on.
Thanks so much. Good afternoon, everybody. I first want to thank Faye and the board for inviting me to speak about my experiences with medical aid and dying. I hope I can make some good points worth discussing later. I prefer to give this type of talk using slides, but that won't be done today, a little too complicated. So I'm basically reading this material, and I'll try to keep a moderate to slow pace. That's tough to do for a New Yorker as I am. My presentation today addresses two areas, the MAID process and grief support. As Faye said, I'm a preventive medicine public health physician, and my career was with the CDC. So I'm not a clinician, and the issues I'm going to discuss today are what happened 3 years ago to me and my wife. So some things may be different now, and we can discuss these issues later during the question and answer question discussions part of the presentation. So this was my MAID experience, and I'm going to go into some detail about that. My wife of 44 years, Maggie, had non-invasive bladder cancer that was diagnosed in 2014, recurred in 2018, spread to her kidney in 2021, and was metastatic to her liver in July of 2022. She was given 1 to 2 month prognosis, and the only chemotherapy medication for this cancer was Keytruda, which has a low success rate. It's difficult to administer, and it has many side effects, some of which are not reversible. The oncologist tried to convince her to try chemo, but she decided to do medical aid and dying. When we started on this journey, we knew little about MAID specifics. We had a consultation with palliative care and with the MAID social worker, but neither was very helpful. My wife's primary care physician was a woman, and they had a close relationship. She encouraged Maggie not to wait too long to set a date for MAID because she could have a complication of her disease that would be unable to give informed consent. They had lots of conversations that didn't include me. I also found out later that my wife's doctor, this was her first MAID patient. So Maggie was having fever and vomiting almost daily, and one day she was so weak she needed to help her get out of bed. And that day she said this would be the MAID day, even though it was a Saturday. And she only wanted me to be with her at the time of ingestion. I notified hospice, and the nurse and others arrived, but they would not go into the room with her. So I prepared the medication, gave it to her, and she drank it and had no problem. Unfortunately, at ingestion, I was alone and in my medical mode. And in my medical mode, instead of being in my loving husband mode. I held her hand, but we didn't say much. I really regret this. I think we both suffered because of it. She for a few minutes, but me for several years. After she was asleep for 4 or 5 minutes, she had an agonal breath, a loud gasp, and a few minutes later, another one, which kind of really freaked me out since I didn't expect that. And then I went down to the living room and I said I felt like I had just killed my wife. The nurse jumped up and hugged me and said it was cancer and some comforting words, but I was feeling very confused and upset. Fortunately, this was a Saturday. Her physician was not in the office, so she was able to come to our house and stayed with Maggie and comfort her for the last 15 minutes before she passed. So my summary of that day was that I did not know much about the maid ingestion process, and I was all alone. What follows are some of my ideas and concerns about MAID that I think need to be considered to improve the process. First, in my opinion, medical aid in dying is more than just a drug administration. It's a major medical procedure and should be treated as such, even though it occurs at home and seems simple. At minimum, a plan is needed to mix the medication, have it ingested, have post-ingestion care follow-up, and address many emotional issues. A maid doula, nurse, physician, or other trained, experienced person is needed for monitoring the process of service delivery. A loved one should not be doing this medical procedure. So what should a person contemplating MAID and their loved ones do for guidelines? Families should look at the Academy of Aid in Dying Medicine website. It's a fantastic website. It has a 77-page guideline with all kinds of information about the whole process from top to bottom. They also have a 3-day day of ingestion guide, which you can easily download. The guideline has information, and I wish it had been available in the summer of 22 when I needed it, and it wasn't released until the fall of that year. So after what I experienced, my recommendation for loved ones is to make an arrangement for a medical assistant to mix and monitor ingestion. The loved one should leave the room during the mixing and ingestion and let that be done by the assistant. That's the medical thing. Then the loved one can come back immediately after the ingestion and focus on their beloved one for the next several minutes and not worry about the procedure. I've been in several support groups, and this was a very common occurrence that everyone felt so rushed they didn't know what was going on, and they needed that kind of assistance. Of course, our families and the patient have their preferences, and some may not want to do it that way, and they want to do it differently, but they should be aware of all the options and the pros and cons. Okay, one last thing. This is not actually related to MAID, but if you are doing a cremation and you are asked to identify the body, my opinion is don't do it. You don't want that image of your loved one stuck in your brain. My daughter stopped me from doing that, and she did it, the ID, and so regretted doing it. So just refuse. That's just an aside that you may run into someday. Okay, moving on to grief. Here's my experience in the 2 to 3 weeks after I lost my wife trying to find grief support counseling. The social worker was of no help. By chance, my physician found a particularly good counselor, and I had individual counseling for 3 months from Empowered Endings. I seemed to have no other options at the time. It was very difficult to find someone. Then a MAID-specific group formed from Empowered Endings and became available in January 23. So that's 5 months after my wife passed, and I joined. I also joined a hospice partner loss group, which also worked very well, but I never told the group that my wife had used MAID. This is a very sensitive issue for us loved ones. So what MAID grief counseling is available now? After the ingestion day event occurs, group grief counseling and support services for MAID loved ones are available in at least 9 states, with several being in San Diego. I've attended several of them myself. Most of them are done by Zoom, and they accept clients anywhere in the U.S. Individual counseling is also available. So this is really not a problem unless there are more clients than there are services available, and that doesn't seem to be the case. Most of the groups I've been on has been fairly small, and they certainly have room for many more. So now let's move to before the ingestion event date. The question is whether grief counseling is needed this time. In my opinion, it should be very helpful to prepare loved ones who are very stressed out and will be more stressed after just losing their loved one. I'm pretty sure there is no policy regarding this issue. So from a policy decision, the first important question is whether such is helpful and needed. I think it would be. So again, I'm talking about before the ingestion occurs, should grief counseling happen? After it occurs, of course, I described there's plenty of grief counseling, but before, there's none that I know of. So if this is needed, how should before the ingestion event date grief counseling be done? Should the prescribing physician do it? What are the institution's roles like UCSD, Scripps, and other major medical providers? What is the Academy in Aid in Dying's position? I assume such decisions are not currently being discussed, but I don't know for sure. One possible approach is to work with the compounding pharmacist. The pharmacy staff usually contact patients to discuss the mixing and ingestion of the made medication, and they provide printed information about that. So we could include a written information about a pre-event and post-event grief issues with referral information that include that with the medication delivery. This would let the family know that it's possible that they could go to pre-event counseling for grief as well as the post-ingestion usual grief group. Another approach is for the pre-ingestion event loved ones to join a post-ingestion event grief group, which may help them prepare them for the soon ingestion event. They then can continue in the group as a post-event group member after their loss. So it'd be like a pre-event person joins, then they become a post-event person, and when finished, they leave the group, and then a new pre-event person joins. So it's kind of hard to follow. It's like coming in new and being with a group who already are grieving their loss, getting your information you need there, and then when your event happens, then you move into that group. But I've spoken to people about this, and I don't think they're too enthusiastic about it. I don't think the grief counseling group leaders even support pre-ingestion event grief counseling, nor the mixed group that I'm suggesting. Lastly, on this subject of pre-ingestion event grief counseling and support, there may be more ongoing about this issue than I know about. So that's my basic summation about what I think is important for us to think about when we're looking at the whole MAID process and how to navigate the different issues that come up, the issues of counseling, when to have it done, and all that are certainly worth discussion. I say in the last issue, I'm supposed to say how I would want to die, and I think quickly would be the answer. And dying while sleeping sounds like a pretty good thing. But I would do MAID or possibly other methods that decrease pain and suffering if that was the situation. Well, thank you very much.
Awesome. Thank you very much. So now if we've got about 5 minutes, if anybody has any questions for him, put them into chat and we will get you some answers. Otherwise, we are going to have like a big question and answer time after all the presenters have gone through. So far, I'm just seeing a lot of chat, a lot of things on chat that show where you can get help with grief counseling. Bob, what did you say about cremation? We can't hear you.
You hear me now?
Yes.
Well, that just had nothing really to do with MAID. It's just an issue of if you are having your loved one cremated, they ask you to identify the body, and that's something I recommend that you don't do. It's my daughter stepped up and did it for me, and she regretted doing it. So you can imagine the image of seeing your loved one after 4 or 5 or 10 days, whatever it is. It's not a very image that you want in your brain at all. So I wouldn't do that. I'd just refuse, and I don't think they can make you do that. Make you do an ID. I don't know.
Does somebody need to do it, Bob?
I don't know. I don't know if it's a law or anything, but they did. I mean, if you have 4 loved ones in a cardboard box, right, and they say, "Do you want to identify her?" and make sure that that's who it is. And I don't know if you're required to do it, but it's just that it's something because of any other kind of images you get stuck in your brain, you don't want that look.
Pam, I don't know, can you put the Academy of,
It's there.
what is it? It's such a long title, I can't.
There were a couple links Faye put into chat
There it is, yeah. Very important that
already.
you know that. How to contact the Academy of,
It's the Academy of Aid in Dying Medicine, they're called now. The Academy of
Yeah.
Aid in Dying Medicine.
AADM, yeah. Okay, that's important to know. It's an excellent website.
I think there's no.
Should we move on to the next speaker then?
Yeah. Our second speaker is Dr. Flora Donkey, the medical director of Apriva Hospice here in San Diego. She practiced for 31 years in family medicine and now in hospice care. Her medical training was at UC Irvine, and she completed a residency at St. Paul Ramsey Medical Center. Dr. Donkey has worked on more claims relating to muscle spasm than other providers in the area, and maybe she can tell us what that's about. I didn't understand that. She's affiliated with Sharp Memorial Hospital and practiced in San Diego with additional offices in Lakeside and El Cajon. Apriva Hospice is one of the few hospices in San Diego County with a Joint Commission accreditation, which shows dedication to the optimum patient experience, commitment to strong interdisciplinary care management, and a robust patient safety initiative. Apriva is also the Honor Veterans Partner. I wanted to quote a former patient who wrote about Dr. Donkey. Dr. Donkey was my mom's primary care doc. My mother was in a memory care unit. I cannot say enough positive about her kind, patient personality. If you are looking for a doctor that truly cares and demonstrates that care through action, I highly recommend Dr. Donkey. And with that, we have the great pleasure of introducing Flora Donkey with us today. Thank you, Dr. Donkey.
Thank you. And thank you, Faye, for inviting me to talk. And I just want to make a comment, Dr. Robert Gunn. That was an amazing talk, and you touched my heart. As a physician, and this is happening to your partner, you should just be the husband. You shouldn't have been the person to administer the drink. So I'm so sorry that had to be very difficult. So basically, we were posed with three questions. One was, why do we support MAID? And it's interesting. I wasn't sure about MAID when it first came out in 2016. I felt like I had to find out more about it. And the more I found out about it and experienced it, the more I greatly, love this available for people in California and the other 10 states and the District of Columbia. Number one, MAID gives you, it respects patients' autonomy. So the patient has the right to refuse life-sustaining care. Why does that make a difference? I met an oncologist. He was in his 50s, and he was diagnosed with metastatic colon cancer, stage 4. And he was asking me questions about MAID, and I finally said, I'm happy to meet the patient and talk to him. And he said, it's me. I'm the patient. And he told me, I'm refusing chemotherapy. I'm refusing surgery. I want to die whole, and I don't want to suffer. And coming from an oncologist who's this is what he does for a living, takes care of patients who are terminally ill with cancer, he was like, I don't want a part of that. And so he chose MAID for himself, and that gave him the autonomy. MAID gave him the autonomy to choose for himself. MAID is also for people who have unbearable suffering, from cancer, from ALS, from COPD, from CHF. There's a lot of different diagnoses that you'd be able to qualify for medical aid in dying. But when you're suffering, like you've got pancreatic cancer, probably the most painful cancer there is, MAID is a compassionate response. It's a compassionate way to assist people who are suffering. The other thing that I love about medical aid in dying is that it allows patients to die with their dignity. When you have a terminal cancer or a terminal illness and your life is spiraling out of control and you don't know what's going to happen day to day, MAID gives you that opportunity to get the control back in your life by choosing the date that you want to die and choosing the time that you want this process to start. But what I found with all my experience is that it also gave families a way to reconnect with each other. And here's these estranged son and daughters being able to reconnect with their parents. And I mean, that doesn't happen all the time, but when it does, it's absolutely beautiful. And so I find that, having the opportunity to say goodbye to your loved ones is priceless, absolutely priceless. What else? Sorry, there's so much to talk about on this topic. I think one of the other questions is that was asked is, what would I like to see change? And I would love to see a clear path for patients with dementia to be able to participate in medical aid in dying. Although I have to say that when this first came out, I was back in 2016, I was taking all sorts of phone calls. So I would go over to people's homes and I'd assess them. And this one woman said to me, it's really nice to talk to you, but why are you here? And I said, well, I was told you wanted to talk about medical aid in dying. She goes, what's that? And the daughter says, Mom, don't you remember? You asked about medical aid in dying. She goes, no, I didn't. And I was like, oh no. Okay. I'm out. And the daughter tried stopping me, like, no, we need to proceed. And I said, I can't, your mom, I'm not even sure she can give consent. And she's like, no, but we've got the two witnesses here. And I go, okay. And then she goes, yeah, my husband's here. And I go, no, you can't, your husband can't be, the second witness. And again, this was all new at the time. And I was just like, wait, I'm right? This isn't supposed to be happening this way, right? So luckily I was able to join the National Medical Aid in Dying. And so I feel like I have more colleagues there. Also, I work closely because I belong in the hospice community. We work closely with Advanced Care Pharmacy, and that's located in Escondido, California. And the pharmacist there, Angela, is a wealth of information. And so I feel like I could talk to her about, my experiences sitting, at like 450 MAID deaths, in the last, since 2016. And so that's been helpful for me. Because I'm like, okay, why am I seeing all of my pancreatic cancer patients? Why are they taking longer to pass away? On average, it's almost like 4 to 6 to 14 hours. And so medical aid in dying, it could be as quick as 10 minutes. My longest was 14 hours. And what Angela, the pharmacist, shared with me is that when you have pancreatic cancer, you need pancreatic enzymes to break down the medication so the medication can be absorbed. You also, when you have pancreatic cancer, you have what we call gastric emptying that slows down, and you need that to be able to absorb meds too. And then usually these patients with pancreatic cancer have very, very high med tolerances, and they're on very high meds, like they're on 175 micrograms of fentanyl and breakthrough other, morphine for pain. And so it's nice. And I want you to know that we all talk about how can we make this process better for everyone. So I talked about why I support it. I talked about what I'd like to see change. And the other thing I'd like to see change, and it's with the help with the Hemlock Society, it's just more education. I just feel like so many doctors, and they're the ones that should be referring patients, over to prescribers that participate in medical aid and dying, but they don't know enough. And even when I was in 2023. I was assisting a patient who lived all the way up in Palomar Mountain area. And in the Palomar Mountain area, this poor woman who had pancreatic cancer, she called 26 hospices to see who would come up there to assist her. And no hospice goes to that area. And so she called me and I was like, oh my goodness, do you know what that means? That if you're not on hospice and you die at home, you become a coroner's case. And I don't know if I want to participate in that. But she begged me and she just tore at my heartstrings. And so I said, okay, let's do this. And I said, and so I called the police department ahead of time and I said, how are we going to handle this? And they're like, well, you're going to have to call 911. So once she passed, we called 911, fire department, sheriff's department. They all showed up with the bells and whistles and the flashing lights and all the bags and equipment. And I stopped them right there. And I said, she's already passed. She took medical aid and dying. And they just looked at me like, we've never done this before. We've never had a patient. And this is 2023. This was just 2 years ago. And so they took my ID and the husbands and the daughters, and we had to give a police report. And we were there for another 2 hours because they were given a police report. And then I was like, okay, we need to hurry because this is Palomar Mountain and it's getting dark. And I don't want to drive in the dark. And they're not going to be able to find this place because the family had to put up balloons for me to find the driveway, the entrance to the driveway. So I call UCSD and they're like, no, you have to have a coroner's waiver. Absolutely. No. And I said, there is no coroner's waiver. And I said, what if we give you a police report? And she was like, no. And I go, let me have you talk to the officer that is here right now. And so he gets on the phone with UCSD donor program, who's always great. By the way, I have a great relationship with them, but they were just like, we can't accept this. And the police officer said, if you want a coroner's number waiver, then I have to call out the homicide team. And I was just like, no, please. No. We can't go there. So thankfully, with these kind of experiences, everyone's getting educated. And even UCSC body donation program, they got educated that, hey, listen, they're going to take the police report number as if it's a coroner's number. And so thankfully, that happened. I know that I've gone all the way up to Santa Barbara. I have helped people in LA County. I've gone to Riverside County. Riverside County is a little interesting because even if they're on hospice, you still have to call the coroner's office and get their permission to get a waiver. So, but hopefully things will, again, they're evolving, and education is sorely needed. Dr. Gunn, I heard you talk about the different like, I'm not sure what Scripps does, and actually Scripps Foundation is a Catholic um, based organization. So a couple of years ago, they sent out a letter to all their physicians, and they said, you cannot participate in medical aid in dying. However, the palliative care team is amazing at referring patients who are interested in medical aid in dying um, to hospices that support medical aid in dying. So even though Scripps physicians aren't allowed to participate, they're one of the biggest referrers of medical aid in dying. So just for you to know that. Sharp also is learning, hey, I could, because I do talks to their oncology and their palliative care teams, and they're also referring to hospices that support medical aid in dying. Kaiser and UCSD are interesting. They actually assist patients with getting the medication. However, you get the medication, they're just like, it's kind of like a Dr. Gunn situation where here you go, and good luck. And I know that there's people out there, there's doulas, there's death doulas, there's people that can help out with that. So familiarize yourself with those groups. I, as a physician, I have a little bit more freedom to assist people like who have ALS and they don't have a feeding tube, they don't want a feeding tube, but they need another way to administer the drug. So what I tell people is that whatever you put in your mouth, you can actually put in your bottom. And I'm talking about medications only. So the main med can go orally and it can go rectally. And as a physician, I'm able to put in a 30 French catheter, Foley catheter. Actually, it's so funny. I have one right here. that wasn't planned, actually, but it's a lot bigger. Usually, when you have a Foley catheter, it's a lot smaller because it's got to go into your urethra. But this is going to go into your rectum, and on this end, I blow up the balloon, and the balloon expands, prevents the medication from shooting back toward the rectal entryway. And I can stir up the medication. I can pull it up in a syringe. I can attach it to the Foley catheter, but the patient has to be able to push down on the syringe. And actually, that's really easy because the syringe doesn't take much. It's usually the weight of your hand that can deliver the medication. You know what? I'm sorry. I've lost control with how long I've been speaking, so I don't want to overtalk. So just let me know when I need to cut off. Okay.
I think you can stop now and maybe get a few minutes of questions, and then there'll be a lot of questions afterwards, if you don't mind.
Okay.
Okay.
No, you're right. Okay,
one of the
sounds
biggest conversations that's been going on in chat is, I'm trying to go back up to the original question. But their question is, what do you think about made for intolerable terminal suffering? And actually, I take that back. It was progressive neurological illnesses.
Oh, absolutely appropriate. I mean, neurological illnesses like ALS, like Parkinson's, we totally help people with a progressive neurological issues. And again, if they don't have a feeding tube, then I'm able to use a Foley catheter to deliver the medication. But, and again, it doesn't take much. It's just the weight of the hand that delivers the medication.
And then another question was, what do you think about the idea of having an IV option for MAID instead of having to do the drink?
The reason why it's legal is because it's not an IV option. So the difference between medical aid in dying and euthanasia or physician-assisted suicide, which are both illegal in all 50 states, is that the patient has to administer the drug to themselves. So IV administration is not an option.
We
And
think
that
it should
kind
be,
of,
though.
what's that?
We think it should be.
I agree. I
Okay.
agree. I
That's
totally
the
agree
point.
with that. Yeah, I totally agree with that. And actually, if I could just slip this in, if I was allowed to say, how would I want to die? Like Dr. Gunn in my sleep. That sounds really fantastic. If not, I wouldn't hesitate to take medical aid in dying. And I know the little tricks about the sorbet. And you take the sorbet, take a couple of scoops of raspberry sorbet or mango sorbet, something strong and sweet, then drink the cocktail, and then again take a couple more scoops of the sorbet, and then let it be. Some of my patients use shots of brandy to follow, or a couple of sips of wine, or whatever you want to do. But yeah, I wouldn't hesitate to do medical aid in dying.
So
Dr.
then we
Duncan?
had a question that goes, which is quicker, medicine in the rectum or the mouth? And then can you also explain, I'm sort of trying to put two questions into one, also why 6 months only?
Oh, okay. That's a lot of questions. So tell me the first one again.
Which is quicker, medicine in the rectum or mouth?
I actually find that in the mouth is faster. I actually find that that's faster, and I can see it being consumed, and sometimes I do peek under the sheet to make sure I've not seen anything coming back, from the rectum, but that usually doesn't happen. But my patients that have been 12 to 14 hours, they have both taken it rectally. But they couldn't take it orally because they were vomiting. They were just projectile vomiting, so they didn't have a choice. And they had pancreatic cancer. So there's a lot of factors there on why it took so long.
Dr. Duncan, I wanted to ask you, a couple of months ago, we had a talk by Tad Pope, Professor Tad Pope, and he's going to speak again in January, of a path for dementia patients to get aid in dying. And you were one of the people who agreed to do it the way he described, sort of the bridge method, which I appreciated very much because it's very difficult for dementia patients to use aid in dying as the law stands now. Do you want to say a little bit about that, or?
Well, what's interesting is that just because you have the label of dementia doesn't mean that you still can't tell people what you want. So it's two different things. It's kind of like, okay, they can, you can still have the ability to say, listen, this is what I want to do. And I think that it really is going to depend on the patient and the family, and really how supportive the family is when it, and if the patient though is so demented that they can't follow directions, it's a moot point. And that's why a lot of people say, okay, we can't give it to dementia patients because they can't follow directions, but some of them can, and some of them are able to. And so I think it's a slippery slope, and we shouldn't just say no to everybody, just a blanket statement of, oh, well, you've got Lewy body dementia. Oh, you've got Parkinson's. So, but not everybody with Parkinson's has Parkinson's dementia, so it's really, I think, a case by case basis. Then that's how it should be handled.
So how do you get around the fact with the 6-month minimum criteria to live?
Oh, well, that's why a lot of times, I mean, majority of the times I go through hospice because hospice vets out the patients. I mean, and they have to, and they do it because they're going to follow Medicare guidelines. But let's say you have dementia and you're just like, I don't want to live like this. And then you stop eating. And people who have dementia stop eating, stop drinking, and I say all the time, water is life. And patients are like, I'm gonna quit drinking and eating so I can qualify for this. And but they're also not hungry. They're also, they're just like, I don't want to continue living like this. Kind of like
So,
the
Doctor,
the oncologist who had colon cancer. He's just like, I probably could live longer, but I refuse to do a treatment. And therefore, you have less than 6 months. Go ahead. I'm sorry.
no, I was just going to say Professor Pope's lecture a few months ago is on our website, and then he will be
Okay,
our next speaker in January,
cool.
again, talking about how dementia patients can get aid in dying, which is really a worldwide problem with dementia on the increase.
True.
And Dr. Danke is willing to follow his guidelines, which not every hospice, no hospice is willing to do that. So thank you very much, Dr. Danke. And so there'll be questions afterwards, and let me introduce our third speaker.
Absolutely.
Thank you very
Thank you.
much. And now our missing participant, Dr. Curtis Kroc, who is new to San Diego, but has already made his mark by agreeing to be on the Hemlock board and getting permission to show Right to Die films at the V retirement community where both of us, he and I both live. He's also come a long way from his birthplace in Arkansas to Stanford, where he got his bachelor's degree, to Johns Hopkins for his MD. He completed residencies in internal medicine, pathology, and pulmonology. He was a captain in the Army and worked for almost 30 years in positions of leadership at the Carley Clinic in Urbana, Illinois. Besides what he learned from patients, he also formed his opinions about MAID from his sad experiences with his two wives, one who lingered with multiple sclerosis and the second who died from esophageal cancer. He is a fellow of the American College of Physicians and the American College of Chest Physicians and is board certified in internal medicine and pulmonary disease. And let's see if our technical skills can get him, who is currently on the airplane but has pre-recorded his talk. John, or who's in charge of that? Anybody?
It's John. He's coming out.
Yep.
Coming up. There he is, Curtis Kroc.
All right, here we go.
Hello, I'm Curtis Kroc. I'm a retired physician, MD at Hopkins in 1961, residency at Barnes in St. Louis, and practiced medicine from 1961 to 2001. So I've had a lot of thoughts about death and dying, as a physician always does. As a practicing physician for 40 years, I attended the final hours or minutes of many patients. Though we know we must all die, we would like it to be at the right time and as comfortable as possible. In this talk, I address 3 topics. First, why I support medical aid in dying. 2, what I'd like to see changed about current laws. And 3, how I want to die. My support for medical aid in dying grew of deep personal grief. My lovely first wife experienced the onset of multiple sclerosis 10 years after our marriage, when she was 38. By 52, she had lost the ability to walk, and at age 55, she entered a nursing home following a bout of aspiration pneumonia with a permanent tracheostomy, permanent urethral catheter, and bedfast. She spent the last 10 years of her life in the nursing home requiring assistance in eating, in turning over in bed, or even with bowel function. Her illness had begun with sciatic pain, and she had a particularly painful form of multiple sclerosis. As she had the chronic progressive form of the disease, there were no effective FDA-approved drugs for its treatment, and trials of the early drugs that became available for intermittent multiple sclerosis resulted in side effects without benefit. She was in continual pain throughout her life, only partially relieved by opiates in massive dose, given simultaneously orally, rectally, and by continuous subcutaneous infusion. For years, she expressed her wish to die, and she attempted to take her life by cutting her wrists, but she lacked the strength, the dexterity, and access to the kind of knife that would have made this possible. She tried to take her life by voluntarily stopping eating and drinking, but she was never able to reduce her fluid intake enough to make this approach practicable. Ultimately, her choice was not to be treated when one of the periodic bouts of sepsis that MS made her liable to came along. We both feared that a time would come when she was too weak even to press the button to summon the nurse for assistance. At the time, Illinois had no law authorizing medical aid in dying, and that's still true. The legislature has passed such a law this fall, but it's awaiting the governor's signature, which is not at all a certain thing. Even if Illinois had passed a law authorizing medical aid in dying, Ruth was not predictably terminally ill within any 6-month period, nor could she have self-administered the oral drugs required for the process. It was more than another 3 or 4 years before she died of sepsis, after spending the last 27 years of her life in pain. As my second wife was dying from esophageal cancer 3.5 years ago, I was again struck that despite my best efforts as caregiver, assisted by hospice, the last days of her life were uncomfortable, and I must live with the sad memories of those last 2 weeks. In general, as a physician often caring for dying patients, I found that despite our best efforts, the end of life was often painful, uncomfortable for the patient, and hard for loved ones to watch. So I came to the belief that physicians should be able to offer patients medical aid in dying. I expect all of you have taken a much-loved dog or cat to the veterinarian for assistance in providing a rapid, comfortable end of life, and have wondered why we cannot offer the same assistance to our fellow humans. While it is true that palliative care and hospice have greatly improved end-of-life care, it is not the case that we can always control pain and discomfort. At present, about 12 states in the U.S. authorize medical aid in dying, which began with Oregon's path-breaking legislation in 1998. And nearly all the states that have such a law have modeled it after Oregon's law. In Oregon, the annual number of deaths has risen slowly from about 18 in the first year to about 2,800 in a couple of years ago. The main diagnoses of people seeking aid in dying are cancer, neurologic diseases such as ALS, and heart failure. About a third of the people who receive a prescription for life-ending drugs do not take the medicine. There has been no abuse of the process, no slippery slope, no evidence for coercion of individuals with disability. Other options exist for self-termination of life, voluntary stopping eating and drinking, or a final exit network, which assists people in obtaining equipment for inhaling 100% nitrogen gas. Canada is experimenting with a much more liberal approach to assisted death, and a number of European countries authorize medical aid in dying, but except in Switzerland, these are restricted to legal residents. Current U.S. laws exist in 12 states. Residency is required except by Vermont and one county in Oregon. 2 physicians or 1 physician's assistant and 1 physician must have evaluated the patient, certified that the patient is mentally competent to understand the consequences of his or her choice, has a terminal illness that is expected to take the life of the patient within 6 months. The physician is also obligated to ensure that the patient is not making the decision because of depression or other mental disorder or coercion by family or friends. The physician should have discussed the options of hospice and palliative care. The patient must have twice expressed verbally the desire for medical aid in dying and must have written out 1 request. The doctor can then prescribe medicine that is taken orally or rarely by feeding tube or the rectal route. The actual ingestion of the medicine must be carried out by the patient. The medications have to be obtained from a compounding pharmacy as powders, which are then mixed with 2 ounces of fluid, which must be ingested within 2 minutes after pre-medication with anti-nausea drugs. The drugs cost about $800, which is usually not covered by insurance. Most patients fall asleep within a few minutes, and most die within 2 hours, although rarely many hours may pass. The death certificate lists the underlying cause of death with no reference to suicide or medical aid in dying on the death certificate. So why don't these laws work for everyone in the states that have them? Well, the biggest problem is a patient who, like my wife, had intractable pain and suffering, but who did not have a predictable death within 6 months. Initiating the process is cumbersome and time-consuming and cannot be brought rapidly to bear. Most physicians have no experience with the process and prefer not to be involved, and the patient may lack the physical capacity to self-administer the medication. And if the patient has Alzheimer's disease or other dementia, by the time they're ready for death, decisional mental capacity is often no longer present. And it is difficult to plan the process while competence exists for use later. Prognosis for death is difficult to estimate in dementia anyway. And for some patients, the underlying disease may make it impossible physically to carry out the self-administration of the drugs. So what changes would I like to see? First, I'd like to see the availability of assistance in dying in all states. Next, I would like to see the 6-month prognosis requirement eliminated. Rather, it should be available to any patient with an untreatable worsening condition associated with great discomfort. I would like to see the option for patients with neurodegenerative diseases such as Alzheimer's to opt in advance for assisted death when certain thresholds of deterioration appear. I would like to eliminate the requirement that the patient must self-administer the medicine, and ultimately I'd like to see the availability of physician-administered intravenous medication for a more predictable, more rapid, and more comfortable death. All of us who have undergone anesthesia or even a colonoscopy probably recall the rapid loss of awareness, waking up to find the procedure is all done. So what would I like to see for my own death? Most of us would prefer the sudden death of ventricular arrest or fibrillation, or the sudden massive stroke. No awareness, no suffering, no fearful anticipation. But only a minority of us finish the course of life this way. Now at age 90, with 2 ultimately fatal health conditions, the end of my life lies not too far ahead, but what it involves is uncertain. As I am experiencing slowly worsening memory, I like the option in advance of providing for my assisted death when mental competence fails, when the balance of suffering exceeds any of life's pleasure, when life becomes confusing, uncomfortable, and meaningless. Ideally, I'd hope for the chance to express my love and thanks to friends and family before that final good night, to forgive and obtain forgiveness. I would choose not to be resuscitated if I suffer an unwitnessed collapse. If resuscitation is attempted, I would want it to be a short code, not a long one. In most situations, I would opt for comfort care over intensive care unit admission. And in general, I would not wish to experience mechanical ventilation. I've seen too many survivors of ICU care go to a nursing home, never to resume their independent lives thereafter. Also, I'd like to be sure I have discussed my wishes with my family, have named the person to manage my medical and financial affairs when I can no longer do so, have covered the disposition of my estate and my body with appropriate wills and advance directives prepared and discussed with family. So this is how I, as a very old physician, view the current status of laws pertaining to assisted death in the United States. We've come a long way. We have a lot farther to go. I hope we will move forward. Thank you.
Wow. We have our work in the Hemlock Society cut out for us for the next 25 years. Excellent suggestions from these doctors.
Yeah. So far, I don't see any questions for Curtis, but there's one for Dr. Danke that is up there at the top. And the question was, are there any options to decrease the time to die for pancreatic cancer?
I'm sorry, you said, is there any options to
Are there any
decrease it?
options to decrease the time to die for pancreatic cancer patients?
Is that with or without MAID?
That is a very good question.
Yeah,
I'm
just
assuming
kinda,
with MAID.
okay. I mean, it's hard because doctors are terrified of high dose narcotics. And we have been beaten, and we've learned that if we overprescribe, we will get damaged by the DEA, by the medical board. So, but let's say you have a diagnosis of uh, pancreatic cancer. What we can do is, put you on a pain pump. I mean, there's lots of options. There's lots of options, and some of this is, we've used. Let's say you're really really suffering and you're vomiting and horrible things are going on, and we need to do this right now. We don't have the 48 hours to wait, and to get a second physician, consult and blah blah blah. Uh, my recommendation would be to get a pain pump and actually put the patient on a dilaudid drip. And also, I use Versed. Versed causes, you get Versed when you have procedures done or operations, and it causes like amnesia. But it's a way to make you sleepy. And uh, so it's compassionate, and it just makes you not feel the pain. And so it's hitting a couple of different receptor sites. Not only the dilaudid is hitting the pain receptor sites, and then the Versed is allowing you to go to sleep. It's kind of like with medical aid in dying, you've got Valium that allows you to go to sleep, and then the morphine comes in with respiratory depression. So is there a way of speeding it up? that's how I would handle it. If we don't have time, we don't have time. And you don't want to stay in the hospital, because that's the other thing. Hospice will actually put people on what we call general inpatient. We call them GIP patients, and they can stay on a morphine drip and a Versed drip or Ativan drip, and they can be compassionately, they can compassionately go that way. They can pass away that way. Sorry, I keep repeating myself. I'm just trying to think, because I'm like, oh, this is an interesting question. But then the other way to do it is, if they want to come home, we would be able to order pain pumps that we would be able to install and manage at their home, at their bedside. And they would contain the pain medication and the Versed. So I hope that is what they were looking. Is that what they were looking for? Or what are the other options?
I'm thinking that sounds pretty good. I don't know if you were reading any of the chat while Curtis
I
was
can't, because I'm
talking.
on my phone. I'm not very good
Oh,
at this. And so I just have this little teeny weeny screen
that's
that I'm
okay.
looking
So
at.
there's this conversation going on about the medication for MAID. And if there's
Yeah.
hospices that the doctors or whatever will help with no extra charge, there's a question about the medication themselves. Um, if you can say, describe that, like in which cases it's covered by insurance, which insurances it's not covered by, and maybe help people along those ways. And if you know approximately how much the medication typically costs. Have I thrown
Oh,
too many questions at you?
I'm so sorry. I'm trying to get back onto you. Someone was calling onto my phone. I'll try to take it one at a time. The MAID medication itself, it's primarily made up of 5 medications. One is Valium. Valium is to help you fall asleep. 2 is, and there's no order in which, because it all comes in a powdered form in a brown bottle. And so the second one I always talk about is morphine. And morphine is there to suppress your breathing. It's 15,000 milligrams of morphine. Okay, so people are like worried that mom's going to pass if they give her 5 or 10 or 15 or 20 milligrams of morphine, when we're giving medical aid and dying, it's 15,000 milligrams of morphine. And so that is to suppress your breathing. And then we have phenobarbital. And phenobarbital is an anti-seizure drug. And when patients' oxygen levels decrease, what ends up happening is that some patients can have seizures. And so we prevent that by giving 5,000 milligrams of phenobarbital. Usually when I prescribe phenobarbital for seizure patients, it's 60 milligrams twice a day. And so you're getting a whopping 5,000 milligrams of phenobarbital. Amitriptyline is an old-fashioned antidepressant. Some patients take it now for prevention of migraine headaches. And usually you get 10, 25, 50 milligrams of amitriptyline at night. We give 8,000 milligrams because we found that at high doses, it stops the heart. And then digoxin is it's not as much used as a cardiac med, but digoxin is a cardiac med, and people were becoming dig toxic. They were regularly taking it, and they're like, well, I'm taking the lowest dose. Why am I becoming dig toxic? And doctors found that when you take a high dose of digoxin, or it's building up in your system, it stops the heart. So we have 2 meds, the amitriptyline and the digoxin, that stops the heart. The phenobarbital tries to prevent the breakthrough seizures, and then the morphine suppresses the breathing, and the Valium allows you to relax and go to sleep. So as I believe Dr. Gunn was talking about it, once you drink the cocktail, then I give, usually to get that horrible bitter taste from the morphine out of your mouth, I give you sorbet. Also, it's the amitriptyline that can cause burning in the back of the mouth. So that's why it's also nice to take the sorbet. But it takes about on average, 3 to 5 minutes to just go to sleep. And then on average, from minute 8 to minute 20 minutes, you lapse into a coma. You can hear everybody, you just can't respond. And what else was I going to say? My last patient who took medical aid in dying, it took him 10 minutes to fall asleep. So I'm like, okay. And this was a pancreatic cancer patient. So I was just like, okay, we're in it for the long run because nobody's awake past usually 8 minutes. And he was still answering questions from his family. He was still kind of nodding, had his eyes closed. Yes and no and stuff like that. Are you okay, Daddy? Yes, I'm okay. Those were the questions. Okay, so what are the other topics? Sorry.
They were cost questions, I think. Cost of the medication, cost of the
Oh, the
service.
cost. Absolutely. It's interesting. The cost of the medication actually went up about $100. It used to be $723, and now it is $823. And I think it's because everybody's, as the pharmacist was telling me, the places where she's getting her medications, they've all increased their costs. So, and I'm not sure if tariffs had anything to do with it, but I just know that it was around this time that everything went up in price. The only people that get it covered is Medicaid patients, people who have Medi-Cal or Medicaid. I have tried forever to try to get TRICARE for Life to cover it. And what's interesting, they'll cover the morphine, but they won't cover everything else. And it's like, what? So, it's hard to deal with the VA system and TRICARE. But that's about the only places that will actually, I'm sorry, Medicaid, Medi-Cal is the only ones that will cover it.
And you have a charge.
I do, because I found that I was actually going to go bankrupt because I'm sitting at the bedside, and if I'm sitting at your bedside, I can't see patients, and that's how I make, that's how I pay my bills. And the influx was, at first I didn't charge. I thought this should be a hospice benefit. And then after a while, it was just like, oh my, I was inundated with requests. And then I thought, I'll charge $1,000. And I thought that'll weed people out. And, actually it was interesting because there's another doctor in San Diego that charges $5,000. And I actually had patients think, why aren't you worth $5,000? I'm not going to go to you because you're not charging enough. And I'm like, really? That's insane. So I found a medium. I felt like 5,000 is way too much. I felt like charging for me to sit at the bedside $2,300 and having a credit card there, and for every 3 hours charging $2,300. And if the patient dies in 4 hours, you get 2 charges of $2,300. I said, you know what? I got to make this easy because this is, I do other jobs too. And so I thought, I'm going to feel like my time is worth it if I charge $3,000 and everything's included. And I'll assist with helping you get the meds. I'll assist with the counseling. I'm there for you. So you know how Dr. Gunn was saying there was no pre-counseling. I'm there. The hospice knows, a Priva hospice knows, give the patient, the family, her cell phone number. And I will start there and walk them through it. So if patients value that, and I'm lucky because my patients do value that. But I understand not all patients can afford that. And there are other services available. But because if you are special and you need rectal administration, then you'll want to be looking for a doctor like me. Or if you are able to afford that, great. Because everyone kept asking me, so when do I pay you? And I go, you pay me when you use me. I will help you get the medications, but you'll pay me once I'm sitting at your bedside. But other than that, I do the counseling because I've done this so many times.
Thank you. I see there's a reference in the chat to FEN, which is Final Exit Network, that it's free and equipment with
That's good.
the charge for equipment. That's a completely different model. It's not the legal model that Dr. Kroc described. It's a model of sort of guided self-deliverance using the nitrogen, inhalation of nitrogen as a method. And it's more flexible than the requirements for aid in dying. And it's, of course, universally available all over the country, not just in the 11 states. So Final Exit Network is, you can find that on Google and contact them if you're interested.
So then we had another question for both Dr. Gunn and Dinky. How do you guys feel about DNRs?
Dr.
Do you
Gunn, do you
want
wanna
one?
answer
Would
that?
you want one? I guess that's sort of the question. Like,
I mean, when appropriate, yes. So what I am right now is I'm a full code because I'm 63, so I'm a full code. However, I do not want this to go on. Like the other doctor was saying, it's like it needs to be a short term if you're going to do coding. And if you find that it's going to be fruitless, and I've recorded myself, I've sent it to my children. I have a spouse on board with all of that. You just have to do a lot of documentation and a lot of conversations. And but if I had a terminal diagnosis, I would absolutely do a DNR. Absolutely. And interesting enough, I was working with a nurse that I absolutely love. She was a hospice team manager, and she had a catastrophic brain bleed. She had something called an AVM, which is an atrial venous malformation. And it just basically an explosion went off in her head, and she had a massive bleed. And her she had filled out a pulse, physician order for life-sustaining treatment, and she filled it out that she was a DNR. And even then, I was afraid that her family would say, no, keep her alive, or we'll sue you. And fortunately, after 2 weeks, after they saw her on a ventilator, and the doctors were going, come on, we need to do something. She's intubated right now. We either trach her but we have to move on. You need to make a decision. What do you want to do? Do you want, and the family actually was like, but I see her opening her eyes, and I see her moving, and I see her, and it's like, but that's reflex. She's not there. She's not there. And it took almost 2 weeks to really convince her family that, this is going to be fruitless. She's going to become a human petri dish, for all the bacteria and everything to attack her body. And I know her. I worked with her for years. She does not want this. She was a hospice nurse. She does not want to continue on in that kind of care. Because I see patients in subacute over at the nursing homes at Jacobs Healthcare Center and at Stillwater. And it's horrible. But, this is what the patient wants. And this is what the family wants. And we have to follow that. Be very careful who you choose, who's going to follow through with who's your power of attorney. Be extremely careful, because you may say, hey, I don't want any of this. And they say, no, you got to do it. So be very, very careful. Luckily, there are doctors that get the DNR and they're like, no, 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 that's what the patient wanted when they had capacity to make this decision. We are following this. This is a legal document. We're going to follow it. And, go ahead and threaten suing us. But there are a lot of other doctors that cave. And, you come on strong saying, I'm going to sue, I'm going to do this, I'm going to do that. If that's what your power of attorney is saying, they might keep you on it. They might keep you intubated. So you really have to be careful who you put in charge of your health care decisions.
Awesome. Thank you. And then Dr. Gunn, do you have anything to add? You're muted still. You need to unmute. Lower left-hand corner of your screen.
I got it. Yeah. Well, I don't have any experience with that issue, but I do have those kinds of things in my will and so forth. Makes me think I better check them out and make sure they're as strong as they could be. But clearly, I think most people want that option to be there, that if they have an illness and they're not going to recover from it, that they should not have be resuscitated and all the stuff that goes with it, or put on long-term respiratory therapy.
If it's any help, which it isn't, I had a DNR and my pulse is on the refrigerator. And then before I had my spinal surgery, the doctor said, do you want full code? I said, no, I'm DNR. He said, well, I can't do the surgery. Okay, then I'm not DNR. So the pulse is still in my refrigerator. I'm in the care center. Nobody knows whether I'm DNR or DNQ or anything. I don't even know anymore, because 3 weeks ago I did a Saturday program on resuscitation, and it certainly made sense if you were terminally ill and pretty feeble and frail and everything else to be DNR, but I'm only old. I'm not frail and terminal or anything like that. So I guess I'm not DNR anymore, but I don't know who would know. My daughter's sitting right here. She would know, I guess, but she's in Australia, so not right now, but
I think it's also, Faye, more important, what are you now, but what do you want? And make sure that that's what's reflected, not
I
what.
want to live. I want to live, And so my program on resuscitation suggested that as long as I'm not terminal, as long as I'm not too feeble, I could possibly recover from resuscitation, although statistically it certainly doesn't seem like. So I'm not a good example of what you're supposed to do.
Oh, yeah, Bob, guys, here, wellness checking, good.
Somebody wrote in the question of what did you write in the letter to your children? So I'm assuming that is in reference to Dr. Dankey's advanced care directive and not a final letter to one's children, if that makes sense.
Say that again.
I think it's in question to what did you say with the conversation. So I've had conversations with my children about my DNR, my advanced directive. And no, I'm not DNR because I'm only 65. But how did you do your letter to your kids? How did you bring up the topic with your kids? Was it difficult? I'm extrapolating on what I'm thinking they're asking.
Yeah, I had a verbal conversation with them both. One is actually pre-law, so he'll be going to law school next year. So I really knew I was going to have a very intense conversation with him one-on-one, separately, because I have two boys, and then with my partner. But basically, just told him my wishes. It's like, this is what I do for a living. I do not want my life prolonged. Oh my goodness, if there's no chance of quality of life, I do not want my life prolonged. Absolutely not. So it was, it's because I have these difficult conversations pretty much every day with patients. And when I do admissions to nursing homes, I have to say, hey, listen, we need you to fill out this pulse, this form, and it's a guideline for us doctors and nurses on what you want us to do. And some patients are very, like, no, I want everything done. And it's like, okay, do you understand what that actually means? And when I talk to them and say, okay, what that means is that you may be on this forever and until you pass away. And they're like, oh, no, that's not what I want. I don't want that. There's a trial period of being able to do resuscitation, but then after that, no. And it's kind of like the G tube also. It's like you can mark on the form a trial period of G tube, but if it's going to be long standing, most patients are like, I don't want it. I don't want it. And but what's interesting is hang on a second. I do tell patients that I do tell patients for the G tube part is I would say do a trial period, because what if you had a stroke and you were just down for a week or two and you just needed enough time for your body to recover? Just can we do that? And most people will say yes. Okay, we can do a trial period. But then there are those that are absolutely not. I never wanted a feeding tube whatsoever. So it just really depends on how do you see this, for yourself. Would you be okay with a feeding tube just to get you over the hump? Or are you absolutely not? Or totally give it to me. I want that. I want to live forever. You have to communicate that. So I think that's what you were asking, right?
I think so.
Okay.
I
I think
that's good.
I just
Okay.
want to give a plug to our next two meetings. We try to have monthly meetings, and we really have some very interesting things scheduled practically till the end of the year. Next year, that is. But in January, I think the 17th, Pam, is that right? We hear again from Professor Tad Pope, our legal scholar for the Right to Die movement, to talk about, again, dementia and the right to die. And then in February, can't remember the date of that, is
14th, Valentine's Day.
Valentine's Day, is Catherine Tucker, who is a legal scholar also, and she's going to talk about psilocybin and the end of life. And that's always a big treat for all of us. And again, we're going to do it on Zoom. So stay tuned to our website, which is hemlocksocietysandiego.org. And you'll see not only the past programs that we've had, but also what we're planning in the future, which is very interesting. And thank you again to Dr. Danke and Dr. Gunn for being with us today, and Dr. Kroc, who is sort of with us in spirit, definitely with us in spirit. And as a good example, he joined the Hemlock board. And if anybody out there is interested in doing that, we would like to hear from you. Chris, do you have any parting remarks?
No, I think you're good. I put in the chat that Tad Pope is January 21st and Catherine Tucker is February 14th.
Oh, we got it close anyway, but check out our website.
Definitely.
All right. Thank you.
Thank you, everybody, for being here
Bye.
today from all corners of the country. And
Mhm.
we are very lucky that we have Dr. Danke in our midst and Dr. Gunn, who I hope will someday join our board. And he has some great ideas. It seems to me if we took all these ideas about how we can have a better end of life, we would have enough material to keep the Hemlock Society busy for the next 30 years. We better get on it, guys. So, okay.
Awesome.
Thank you.
Thank you, guys.
Thank you. Thank
You
you
too.
all. This was marvelous.
Bye-bye.